As I have about 15 minutes to present, and as I have 22 slides to present, I'm going to go through this rather quickly, but it's me. I am loquacious and verbose. There's no question about it. A lot of what you will see here are probably techniques that you have seen before, so this is a refresher. The first thing that I want to do is to provide some quick reminders about psychosis, just as a refresher. And the first thing that I want to start out with is that we need to remember that the hallucinations and the experiences that these people have are not the disease in and of itself, that this is an experience that is symptomatic of some other process going on, whether that's too much dopamine or too much glutamate or whatever it is that it might be. Generally, there's some other underlying condition that's producing this. And, you know, just as a fever is the symptom of some other illness, so is hallucinations a symptom of some other underlying condition. So by no means is this voluntary action on the client's part or manipulation or anything like that. Today, we're going to go through hallucinations, delusions, and negative symptoms techniques for thought disorganization is also a very common issue. We're not going to go into that because I don't think we have quite enough time to do that, but we can get to getting to some strategies that frontline case managers can use, because it is you guys that really make the first impression, do the engagement, and build the solid ground underneath the two of you so that other work can be done. So we're all pretty familiar with what a hallucination is and a delusion. Negative symptoms are less well understood, so we're going to go over a little bit of that as well. Again, thought disorganization isn't one thing that we're going to really concentrate on today. So the first thing that I would want to remind everybody is that when we work with folks, really psychosis or not, but certainly with psychosis, we want to start in the adaptive mode, which means that even if you're the assessor, if you're the person who does nothing but assessments, to begin to relate to this person with regard to their interests, their strengths, their hobbies, what they enjoy, the things that nourish their soul, just like there are things that nourish your soul, whether that's painting or writing or playing the piano or whatever it might be. And even if there are just simply interests that are important to this person, for you to be able to be genuinely curious about those interests and ask for more information. One of the clients that I've had a fascination with learning how to play the piano, but knew nothing about the piano. And I love to play the piano. So we got him hooked up with a piano and a piano teacher, and he's been taking lessons ever since, which has been about 1.5 years, which is kind of amazing for this particular patient. So even if the person hasn't engaged in whatever it is they're interested in, it's still a topic of engagement and curiosity that you can learn more about. Always emphasizing that we're working together as a team, that there's some stuff that this person knows that you don't, and can give you hints about working with them. And there's things that you know that this person doesn't, and it really needs to be a team. Be okay with not knowing the answers. Be okay with suspending your belief about, is there a chip in my brain, or is God directly talking to me? Suspend your disbelief in that and really look for the emotion behind that and work with that emotion. And look for what it is that this person values, what their goal is in having a chip in their brain, or in feeling like God has spoken to them. Does that make them feel a little bit more special? Is that providing them with something that they wish they had in their real life? And then work from there, if that makes sense. Please ask questions as I'm moving along. Beginning steps are to, once you've got that adaptive mode in and engagement up and going, we'll want to work on, again, structuring the session with start, socialize, target, action review, and take home work. For case managers, you can do this. You can structure a 5 or 10-minute session in a start structure. And the cool thing about that is that clients will begin to understand that this is the way that you operate. When you go into their office, the first thing you're going to do is ask about their day and their week. You're going to review homework and try to figure out what is most important to deal with today, collaborate on that, do some strategies, techniques, and psychoeducation, and have the client review. Don't you review, have the client review what the session was like. A lot of my clients can't remember what the session was like right at the end of the session. And so what I'll do in a case like that is I'll take notes and show them the notes that I've taken, as we're going through session, and I'll present them with the notes afterward to help them review, and then they can take a copy of those notes home with them to look at once they finish the session, because that memory can go pretty quickly. It's important to do some kind of a formulation, and case management formulation is really revolving around behavioral targets, history, and beliefs and thoughts. So what is the behavior that you're looking at or working with that needs some guidance and some support? And what's the history behind that? Behaviors don't just come out of absolutely nowhere. There's often some kind of event or environmental circumstance that's reflected in the symptoms that this person is showing. So you'll want to get a real nice, thorough history of what's going on. So many of the symptoms are reflective of what's happening with that person in their life or in their previous life as a child growing up. And of course, we want to get to what are the underlying beliefs and thoughts about what's happening. What are they doing with their whatever event stimulated the process for them? So it's a lot like that old, what's the antecedent? What's the belief about the antecedent event, and what are the consequences about that? And once we've got those beliefs and thoughts, we begin to can mold and collaborate and guide into different ways of thinking, or at least propose new ways of thinking. We want to really recognize how much symptoms are reflective. One of the interesting things I found as I was reviewing artwork is taking a look at artists who have had schizophrenia, and that has been reflected in their artwork. This was done by Edward Munch, and he had a father who was a priest and was a very, very overly religious, and at the same time would tell the kids very, very just scary stories about ghosts and demons in the closet. So you can see, and if you go and look at his work, you can see a real transformation of the paintings that he's putting out, and that can be just perfectly paralleled with his course of schizophrenia. Now, he had a lot of other things going on as well that might have contributed to his artistic endeavors, but I thought that this was a really good way to reflect how symptoms really do play a part. I'm going to give you a real quick lecture, I guess, on brain anatomy to help you understand a little bit where voices come from. So here we have some interesting things in the brain, little nuggets of things. And here we have what's called the ACC, the anterior cingulate cortex. This little bugger in here monitors what happens in terms of sound coming into the brain. Broca's spot is the place having to do with speech, and Wernicke's area has to do with speech comprehension. So what happens is that in the normal conditions, we hear something, we're forming some sentences about that. All that information is monitored by the ACC. Then it goes to this place where our brain then makes some sense out of it, and then it gets to our ear. But what happens sometimes with some folks is that the ACC is cut completely out of the loop, and it goes from just speech to comprehending speech, and there's no monitoring going on. So you can imagine if there's no monitoring or safe gap in the brain to help you determine what's real and what's not, that can get very cloudy for you. And we hear things that we weren't intended to hear, or the brain makes a different interpretation out of what we're experiencing. That's kind of a very, very, very basic anatomical explanation. Does that make sense to you guys? Yeah. So there's something in the brain that really is short-circuited that can contribute to that, and that's where that baby is, right there. And of course, once we're hearing voices and experiencing them, they can seem so, so real and feels like there's absolutely no control. Oftentimes the voices report that they know absolutely everything and they're going to hurt this person. And of course, if any of us were in that situation, we would be in shock and, you know, ready to fight or hide, one of those things. So when we're talking about voices, we want to approach it very gently, ask permission, describe what you're observing. Sometimes I'll see a client who's internally stimulated as we're even talking. And so I might say, are you hearing voices right now? Yes, I am. Would you be willing to talk with me about them? Sometimes yes, sometimes no. And so however they respond is the way that I go, and let them know, when you're ready, I'm right here. So I'm here when you want to talk. If this is bothering you, I'd love to explore that and help you lower your distress. There's all kinds of things that we could possibly try together. And let's take a look at some of the things that you've tried and see if any of those have been helpful in any way. Clients can come up with some really interesting ways to manage their voices. And oftentimes it's really good advice to listen to what they've done because they have some, you know, experience with that. So tips to manage voices. You know, the first order is usually distraction. Distraction works, like watching TV. Distraction is about being a passive participant in an activity. I don't have to think, I don't have to do, I'm just distracted. That works, but it's not a very enduring strategy. In other words, I have to actively distract myself all the time for that to work. But focusing is also another way. I don't even think that I put this on here. Vocalization is a kind of focusing. Focusing on something is often much more helpful. So focusing on doing the dishes, or focusing on doing the laundry, or artwork, or playing music, or whatever it might be, is often the better way to go. Vocalization is really important. There is something about vocalization which includes sub-vocalization. In other words, kind of whispering very quietly to yourself, humming, singing, that interrupts that pathway where voices are. So that's a really good way to help people to reduce their distress, singing and humming out loud. And at least when I'm alone in the house, I wander around and sing and hum all the time. Very glad that nobody's watching, but that's something that people do on a regular basis and might be helpful. Wearing earplugs in one ear is kind of helpful. Not for everyone, but it can be helpful. So that might be, you know, just you can buy earplugs and just stick an earplug in one ear, right? Or wear one earbud and listen to music in one ear. There's been a little bit of research about which ear, if you want to do it in your dominant ear or your non-dominant ear. And I think really the upshot is that the client really has to experiment with that and see which ear works better, if that's something that tends to work for them. Over time, we have recognized that that doesn't work in the long term, but it can in the short term be helpful. Here's the focusing part: concentrating on stuff the client really loves to do, or can do, or needs to do, and they're willing to do it. So crossword puzzles, puzzles of any kind, crafts, household tasks, anything that they can fully bring their mind to, 100% is going to be helpful. Look, point, and name are good. So this is a technique where we say, you know, we just point at objects in the room. It's a grounding technique. We say lamp, right? I say computer monitor, or book on my wall here. Just simply looking at things in the room, pointing at them and naming them. That can bring the voices down a bit. Also relaxation, of course, breathing activities. Square breathing, you're probably familiar with that. Breathe in to the count of 4, hold to the count of 4, breathe out to the count of 4 times. Works really wonderfully. But I think the upshot here is too, when we're breathing, we can actually trigger our system to relax without our permission. And that is by breathing out longer than we breathe in. So like counting in to 5, breathing out to the count of 7 to 10, right? There's something about this that really turns on I think it's the parasympathetic nervous system, where the system actually relaxes. That's why when we all take a deep breath at the end of a stressful moment, that's what our body is doing. We do it naturally, and some folks don't. And so we have to kind of remind them of that. Research tells us too that if we can set boundaries with the voices, things go much better. So some of my clients are just so scared of their voices. In no way, shape, or form would they want to have a conversation or set up boundaries. But many of them are curious about that, to see what would happen if I didn't bump the car in front of me, or if I didn't check the room for bugs every 5 minutes. You know, it's worth an experiment to see. There's other options too, like I'll talk to you for 15 minutes in between 7 and 7:15, but not more than that. Or I'm going to listen to the voice that's helpful and ignore the one that's not. Or I'm just going to, just let them know that they need to be kind, right? Any kind of boundary. So when the client's able to do that, research shows that their distress lowers and that they have more influence over their voices than those who do not attempt to set boundaries up. It's sometimes hard to convince a patient to do that. Any questions about voices at all? I'm going really fast. Let's move on to delusions then. So in dealing with the delusion again, let's hope that everybody has started with the adaptive mode and working with this person to develop that trusting relationship, and you've suspended disbelief. Your goal here is to kind of identify what's going on with the delusion and how that delusion is affecting the person's life. I once was at a farmer's market, and there was a woman who talked about I think she called them contrails, those airplanes that leave steam behind them when they fly across the sky. And she was pretty convinced that those were poisonous gas dropped by the federal government, and that they were basically seeding the population with poison. Other than that, her life was great. I mean, she was fine. She could work full time. She had a great job, but it was that one little odd thing. And if a lot of people have really odd beliefs in the world and do just fine. So our goal is not necessarily to rip the delusion away, but at least to make it more manageable if we can do that and find ways to help them experiment with their situation. How frequently does this come up? Empathize with that. If I were in your shoes and I was hearing that, man, I'd be scared to death too. And sometimes you can't get them away from that. And so we just have to say, okay, well, I tell you what, let's work on your goal of taking a class, or your goal of getting out of the house and walking around the block a couple of times, and take it back to what their goals are, rather than trying to dissipate a delusion that you will not be able to argue this person out of. Think about the person's history and see again what might be reflected in this delusion that occurred in the family's history, and that gets you to a place where you can be curious and want to explore more, or work with the therapist and have, let them know what this is about. And of course, become familiar with that list of unhelpful thinking habits, which I included, and hopefully you all got that. Did you get that list with the PowerPoint? Nope, maybe you will. I'll see if we can get that to you at some point in time. Remember, scope of practice when we're dealing with this as case managers. You don't want to get deep in and start rooting around in family dynamics. More so, you want to be understanding, be supportive, be empathic, and help to guide them back to what their goals in life are. Okay. So be open-minded about what they're telling you. Not all the delusions, again, interrupt somebody's life. Don't argue with them. That's never going to work. And the alliance that you have will be disrupted. No question about it. But when people are in the middle of something and panic, sometimes it's helpful just to have them look up and look at you or look at the room and ground themselves. Have them tell you what you see, what they see, and then keep with that rather than trying to convince them to not believe something. So believe what you see rather than what you believe. You can also normalize this, because there's a lot of times when I'll think I'll see something, but I really don't. It's not that way, and I have to go back and check. And I'm sure that happens to all of us. And so we can normalize in the best, in the easiest way that we can. Find common ground. Again, for me, it was piano lessons. And I don't play well, but I do play. So we're kind of in it together. And let them understand that why they're afraid, right? So that you're not just hearing this as some unreal fantasy that they're going through and you want to help get them through it. That if you were in their shoes, you would be feeling much the same way. Let's move on to negative symptoms now. Negative symptoms, as a reminder, are some part of the person's personality structure that's been taken away from what they used to be before. And so a lot of that is energy and joy and, being with other people, engaging in hobbies, going out. These negative symptoms are really, really important. First of all, because they're not fully understood. They're harder to notice than positive symptoms, so they often don't get as much attention either. Negative symptoms are less likely to get somebody hospitalized, for example. So they don't require that immediate attention that positive symptoms do. So let's take a look at this. It would seem that people are shutting down, because they don't want to have anything to do with what's happening around them, or they're depressed, or, as we hear from families, they're lazy or unmotivated or whatever that might be. What may really be happening is that the internal emotional arousal from the process of this disorder becomes so overwhelming that the body naturally shuts down because they can't handle the overloading stimulation. That's one theory of what we're seeing. So it's not that they're understimulated when they're having negative symptoms, but rather emotionally overstimulated, and that's the body's natural response. We also know that negative symptoms are due in large part with defeatist self-beliefs. So if this is a person who's been told they can't, and they felt awkward most of their life and not really fitting in as what happens in prodromal situations, this person may have developed defeatist attitudes, or may have heard that over and over again from family members. It may be a result too of medication, in which at which point it's really kind of, I don't know if it's an iatrogenic, means that it's due to the treatment itself. So there's a side effect from some medications that can cause sedation that look a lot like negative symptoms. But those are not primary negative symptoms. Those are what we call secondary negative symptoms. And that can be worked through with maybe a tweak in medication or working with a psychiatrist. But it can also be family and all sorts of other environmental stuff, anxiety. Perceived criticism is a huge factor in developing defeatist beliefs and entering into that negative symptomology. We think maybe that there are some anatomical differences in the brain, which of course, we can't know that for sure. We're learning about that. But even if it's something in the brain, remember that therapy and treatment can change the architecture of the brain. Okay, so it's not just, that's the way it is. We can work with it. Techniques would include activity monitoring and scheduling. You use the same form for both, right? So the first time around, what you want to do is just simply monitor what the person is doing, but not change anything. And then when they bring this back, is to go over and say, what would you like to be doing instead? What are some things you would be doing if you weren't like washing your hands all the time, or if you weren't checking your apartment for bugs all the time, what would you like to be doing and when would you like to do that? And then fill this in and see how that goes. Another thing that's really good for negative symptoms is to schedule planned activities and rate the sense of mastery and the sense of productivity about doing that activity. Those two things, is it pleasant and am I productive and can I master it? Working together really heightens a person's sense of self and empowerment and teaches them, right, what they can do to bring themselves up out of a depressed moment. So tips are being active even during session. I will frequently toss a ball back and forth or make up a game around some strategy, modeling appropriate behavior as you do that. Ask the client, what are they doing when they're feeling more energetic and more happy? And discuss kind of bringing those activities in as a possibility. Bike riding, I've used bike riding, walking, I've gone on walks with patients outside the agency, wandering around as long as I take off my identifying features. Once even tossed a football back and forth with somebody who found that to be kind of fun. Right, we just need to be careful about HIPAA and all of that other stuff. So be aware that negative symptoms are not about being lazy or not wanting to do anything. That's not true, right? There are all kinds of things going on. There is a sense of anhedonia sometimes with people, and anhedonia means inability to feel pleasure, right? So this is hard when it gets to this place, and a lot of encouragement and support is going to need to happen there. So now I can take a breath. I hope I got through that in quick enough time. And I wonder if you have any questions about that.